Hi, we're Group 29, and our project was Diabetes Prevalence and Geographic and Financial Barriers to Food Accessibility.
Our research question was, how does the prevalence of diabetes correlate with the existence of food deserts in California based on geographic and financial accessibility of healthy food options? In our background and prior research, we found that nearly half of the American population are at risk for diabetes, disproportionately affecting minorities in lower socioeconomic brackets. So in the 2016 California Freshworks Food Access Report, we found that 1 million Californians live in food deserts and 45% are low income, facing high poverty, lower education, and higher unemployment. An Improving Food Access in California report by California Department of Food and Agriculture found that challenges such as long distance to grocery stores or reliance on convenience and fast food stores with cheaper, high caloric foods can lead to unhealthy diets and an increased risk for diabetes. So as a group, we hypothesized that differences in socioeconomic status through factors such as income level and geographic location significantly influence the prevalence of diabetes as they determine the accessibility and affordability of healthy food options. So residents living in food deserts face constraints in these factors, limiting their access to healthy food and potentially leading to a higher prevalence of diabetes.
As for the data, we utilized two data sets in our analysis, the first one being the USDA Food Access data set. This data set allowed us to look at the existence of food deserts based on geographic and financial accessibility. Some variables we used from this data set included low income tract status, low access tract status, poverty rate, and median family income. The second data set that we used was the Congressional District Health data set. We used this data set to look at the prevalence of diabetes. We merged both data sets on common census tract number.
All right, so our first visualization for EDA is this distribution graph, and this really helps us hone in on distribution of a single variable, showing how variables are spread and where they concentrate. And so these two examples are the median family income and estimated population affected by diabetes.
The next visualization that we used were box plots in order to see, again, like the distribution of different variables. So in these ones, we looked at low income tracts and then low access tracts.
Our third visualization is this bar plot, and this is really great for helping us compare categorical variables. So we can easily compare which categories have higher and lower prevalence. And so in this example, we are looking at counties in California, and we're comparing whether they have higher or lower average diabetes prevalence. And this can be really useful in helping identify regional disparities and focusing public health interventions in these specific areas.
Another visualization that we use is a correlation matrix heat map. And this plots all the different variables with against each other, and this allows us to see whether a negative or positive correlation exists. Red being positive correlation, and then blue being negative correlation.
All right, and our last visualization is this regression line, and this helps us visualize the trend and strength of the linear relationship on the scatter plot. And basically, we can see the general direction, either positive or negative, and strength of this relationship, and the strength is kind of represented by the steepness of the slope.
Moving on to our EDA and analysis and results, we ended up upon three central findings, which were the significant positive correlation between low income, poverty rate, and low access with increases in estimated diabetes per tract. Overall, we learned that the distribution of median family income, the histogram shows the distribution of median family income across the different census tracts in California. The distribution appears to be a right skewed, indicating a larger number of census tracts with lower median family income. As for the distribution of diabetes prevalence, the histogram shows the distribution of estimated diabetes prevalence across different geographic areas in California. The distribution is roughly normal, with most values centered around the mean, approximately of 10%. Key observations reveal a strong link between socioeconomic factors and diabetic prevalence. There's a negative correlation between median family income and diabetes rates, indicating that higher family incomes are associated with lower diabetes prevalence. Conversely, a positive correlation exists in between poverty rates and diabetes prevalence, suggesting that higher poverty rates are linked to higher diabetes rates. This is further reinforced by the positive correlation between low income tract and diabetes prevalence, emphasizing that lower socioeconomic status is associated with higher diabetes rates. Scatter plot analysis supports these findings, showing that median family income increases, diabetes prevalence decreases, likely due to better access to healthy food and healthcare. Conversely, higher poverty rates are correlated with higher diabetes prevalence, likely due to limited access to these resources.
In conclusion, the increasing prevalence of diabetes has become a significant concern in the United States, affecting nearly half of the population or putting them at risk, while factors like obesity and lack of physical activity contribute to this rise. It's notable that certain minority groups, often found in lower socioeconomic brackets, are disproportionately affected. Diabetes, primarily influenced by diet, is also impacted by the availability of healthy food choices, which can be limited by economic factors. Our analysis has revealed that communities facing financial hardships and limited access to nutritious food, as evidenced by the existence of food deserts, are more likely to have higher rates of diabetes. This correlation underscores the importance of addressing economic disparities and improving food accessibility to combat disproportionate burden of diabetes. We advocate for public policy changes aimed at eliminating food deserts to relieve the strain on these communities and reduce the prevalence of diabetes as a whole.